Let us call Dr. Manoj Kumar, the next moderator, and experts Abhilash Nair and Sanjay Saran for a case-based discussion regarding a 54-year lady planned for gallstone surgery on multiple OHAs and HbA1c is of 9%. Dr. Manoj, it's all yours.
Good evening, everybody. Thank you, sir. And one small correction. We have Dr. Shiva Prasad KS with us. Dr. Saran couldn't make it today. So Dr. Shiva Prasad is the expert with us. And welcome Dr. Shiva and Dr. Nair. So today we have a case. We had a 54-year-old lady who came to our clinic. She was a non-diabetic for last 10 years. She was obese and non-smoker. She had a sedentary lifestyle, homemaker by occupation, had an uncontrolled sugar with HbA1c of 9. Patient was on glimepiride 2 mg once daily, metformin 1000 mg twice a day, and sitagliptin 100 mg once daily. She underwent a routine ultrasound for something else and was found to have cholelithiasis. Now this patient came to us and she was bothered that whether she should underwent a cholecystectomy. So my first question is to Dr. Abhilash. So what do you think, Dr. Abhilash? How should we proceed on this?
Yeah, thank you, organizers, for inviting us for this session. Actually, a very important topic and a very common scenario also, that that a person, middle-aged female, who is obese and diabetic, presenting to us with asymptomatic gallstone disease or incidentally found gallstone disease. The thing is, regarding how common it is, in Indian scenario, it is around 7 to 10% of patients even without diabetes. The general population may have gallstones, whereas in other countries where obesity is more common, it goes up to 20%, and diabetes increases the risk by 1.5 to 2 times. The importance of knowing how common it is that you cannot go and do surgery for each and every person, and most of these persons do not develop any complications with this cholelithiasis over their lifetime. So the dictum is, if the patient is symptomatic, you go for surgery. The surgeons in our panel will have a better idea on that, but if the patient is not symptomatic and if there are only certain indications, we need to go for surgery.
So, very true. Yeah. Yes, sir. So, Dr. Nair, very true. So, there are few things about cholelithiasis and especially in diabetes. There was a time when it was taken as a precancerous condition, and now that has not been proven unequivocally. So now we do not take all gallstones as precancerous, and surgery is not indicated in all the patients. But yes, there are few areas where you should think about surgery. So my next question will be to Dr. Shiva Prasad. What are the indications when we should think about cholecystectomy in these patients? So,
Yeah,
sir, we will take these questions later on.
Yeah, as told by Dr. Abhilash, these gallstones are even more common in diabetic patients, 2 times more common compared to non-diabetic patients. We operate patients when they have symptoms. If they come with a biliary colic, usually if there is a recurrent attack of biliary colic, that is one indication, or if they present with acute cholecystitis. These are 2 major indications for doing a surgery. There are other conditions like if the patient has a precancerous condition, like the patient has a adenoma, or a patient has a porcelain gallbladder, or if the gallbladder stone is more than 3 centimeters. These are the situations where we indicate surgery even if the patient is asymptomatic. Most diabetic patients, when they have gallstones, we can follow up if they are asymptomatic. And even the first attack of biliary colic, we don't have to operate. We can follow up the patients. When we follow up, most of them don't have a recurrent attack. So recurrent biliary colic and cholecystitis are the indications for surgery.
Yeah, very well said, Dr. Shiva. And in some cases, if the patient had a history of pancreatitis, or if there are high chances of GB stones passing into the CBD, then we also think about going for the surgery. Yes.
Before LabCorp came into existence. Now, with LabCorp available almost everywhere, surgeons they are changing these guidelines. Because what for we are waiting for? Why not to operate once a single large gallstone is there, multiple stones are there, one of them stone is out of multiple small stones, one of them or few of them are likely to slip into CBD. That will be a real problem for not only for the patient but also for the surgeon, because ERCP is still not that commonly available everywhere. Secondly, if large stone is there, that is likely to lead into this acute cholecystitis and this empyema or any such complication, even rupture of gallbladder, whether outside or in the colon or something like that. Then it will be a real problem for the patient as well as the treating surgeon. Particularly in diabetic, we have more chances of getting acute cholecystitis flared up and empyema. Then why to wait? LabCorp is available. Patient has to be counseled that you can wait because you are not having symptoms, but this can cause some complication. Then it's better to operate right now rather than waiting for the complications and then come for surgery. I think my surgical colleague shall agree
Yes,
with
yes, 100% agree with you.
So, sir,
See,
it's a
actually,
back-
sir, we mixed up two things. You started with that asymptomatic gallstones should not be operated except, वो except नहीं बताया. What you sir told was that if it is a biliary colic, if it is acute cholecystitis, that means
large size stones, sir, more than 3
large
centimeters.
size, small size, multiple stones.
Multiple
Then
stones,
diabetic, there are
if the
chances of gangrenous gallbladder, rupture
if the chances of slipping into the
Perfect.
CBD, those are the things we
So-
have to consider.
Yeah.
The blanket statement cannot be given that
Yeah.
all the cholelithiasis should be operated. I agree, you want to say that, but at least medical community do not agree. Till now, we do not have the evidence that every GB stone should be operated.
No, 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 no. GB
Categorically-
stones in a diabetic patient should be removed.
Must
It's not a
and-
generalized statement
That's what I'm saying,
because
sir, must and should are two different things. So, this
Not
is not a
must.
must.
मतलब ये है कि हमने पेशेंट को ऑफर करना है कि you should get yourself operated. You can still wait for some time, but it can be detrimental to your health later on.
Yes, sir.
That's why you should get yourself operated.
we are discussing gallstones in a diabetic vis-a-vis non-diabetic.
Yes.
अच्छा,
Sir,
secondly,
there should be one caveat which I wanted to tell,
Yes, sir.
that either we should ask our patient to bring her A1C down to 7 if she want to remain with gallstones. If she cannot because she is getting a sitagliptin full dose, metformin 1000 and glimepiride, still her A1C is 9. It means there are more, she needs much better control. Either the patient should have a better control of diabetes and should bring her A1 to 7, or she should plan for surgery, because with this condition she is going to land into trouble with perforation,
Yeah.
with rupture of this. We are seeing it daily, me and
yes,
Dr.
Dr.
Chaudhary, we are
Chu,
working
you must
together.
have seen
We are
so
coming
many
to those
empyema gallbladder cases when I operated at your center.
Yes, this is what I wanted to.
We
One
are
thing-
coming to those questions.
Wha-
We have uncontrolled diabetes.
One thing away from medical evidence is, in the era of Mr. Ramdev, we cannot have symptomless gallbladder at one stage or every morning he is asking the persons to move the abdomen. Kapal Bharti. How the stones can be symptomless?
So these things are beyond medical thing. We will get back to our next question. So if we plan to take her to surgery, then how will you like to control the sugars, Dr. Nair?
Yeah. So basically,
It's fitting.
as the patient has been decided for surgery, as the patient is not exactly having symptoms right now, and we have some time to get good glycemic control, I think she needs to have better glycemic control rather than an HbA1c of 9%. There are no exact cutoffs that where above what HbA1c you should not allow elective surgery or something like that. But definitely the complication rates associated with surgery, post-op complications are greatly increased at a HbA1c of more than 8%. Certain studies with more than 500 patients have shown that the odds ratio of having a worse outcome after surgery is more than 6 if you have an HbA1c of 8% or above. But if you have a HbA1c of even above 7%, still the odds ratio remain above 2. And the best would be if you can achieve an HbA1c of 7 or below. It is good, well and good, but it is not practical in most of the conditions. There the things boil down to getting the acute blood glucose levels or the blood glucose levels under control, where again there are no exact recommendations, but generally a fasting blood glucose of less than 140 and other blood glucose values of less than 180 should be enough for a routine elective surgery to be done without too many complications.
So beautifully depicted, Dr. Nair. So yes, this is a gray area. There are no exact evidence till now where we can say above this HbA1c we should not go for a surgery. But there are few evidences which are clear that with every even slight increase in sugar levels, the post-op complications, perioperative complications, as well as sepsis will increase significantly. As to when we should ask the patient to wait for some longer time, ADA says that there is no clear-cut cutoff, there is not enough evidence, but some societies like Australian Society and UK societies, they say if HbA1c is above 8.5, patients should be made to wait for slightly longer. Even then, they are not saying you should target HbA1c below 7, because we all know in practical purposes, most of the patients do not achieve HbA1c below 7. So that is the difference. Now, we have to think about whether in this case, it is asymptomatic. We have to think about surgery. We can wait for some time. Control the sugars and then send it to our surgeons. They can take care of the rest. But if it is an emergency, in that case, we bring down the sugars immediately and surgery should not be delayed. So that is the thing. If it is a emergency surgery, or in this case, asymptomatic cases, we are planning for a surgery for longer. And even then we explain the patient that, sir, we can wait for control of sugar, but there is no guarantee that you will not end up in cholecystitis. They might not have cholecystitis in next 10 years, and they might have in next 10 days. That is something we always tell all our patients. So, Dr. Shiva, what do you say about the risk of elective surgery in this uncontrolled diabetics, just like our patient? If this patient was to undertake a surgery, what are the risks and how to mitigate those?
Yeah. So all uncontrolled diabetic patients, they tend to have poor outcome, whether it is gallbladder surgery or thoracic surgery, for any surgery. The poor outcome is in the form of increased cardiovascular mortality. There is an increased risk of sepsis in the hospital and delayed wound healing. There is data which shows that for every 20 milligram increase in the blood glucose levels, there is a 20% chances of having increased chances of having complications. So as you told, it is difficult to achieve long-term glycemic control for elective surgeries like this. But if we control the blood glucose levels for the 1 to 2 weeks prior to surgery, targeting a fasting of less than 140 and a peak postprandial of less than 180 to 200, we should be able to bring down the risk of complications in the immediate pre and post-operative period.
So, very well said, Dr. Shiva.
Sir,
yes.
Should we attach so much importance to HbA1c? In such cases, if we monitor the blood sugar levels every morning, daytime, after lunch and after dinner for 3, 4, 5 days, few days, and if that is coming near normal, why not to take advantage of surgery? Because HbA1c is likely to take longer time to come down with the remedial measures. So it is better to monitor uh, blood sugar levels for few days and then take up for surgery, in my opinion. But other surgeons
Yes,
can
sir.
also comment.
It's the same thing I told. We will not wait for the HbA1c to be controlled. 1 to 2 weeks of good fasting and postprandial control is sufficient for surgery.
That is to highlight the point.
By having said that, there is importance for HbA1c also.
That's
Yeah,
important.
because there are the long-term glycation of proteins throughout the body also impairs healing process after surgery and can alter the stress response and reparative response. So that's why if it is good, if you can do that, it is okay, but it is not at all hindrance for surgery. Any HbA1c level you can go for surgery, provided you can have a good perioperative glycemic control.
Also, in certain conditions like empyema gallbladder or maybe some kind of abscess in the body, the sugar goes haywire and it is very difficult to achieve
Unless
the
we do
optimization.
surgery,
So unless
Yeah.
it's like doing the surgery to control the sugar.
Emergencies we don't wait.
And moreover, in lab surgeries, we don't bother much about the wound infections also.
If it is a perforated
there are less
gallbladder and
chances.
all those things. Yeah. For emergency surgeries,
Dr. Manoj, are we not mixing up two things? Once we started the case, we started a silent patient who came to us with ultrasound with no symptoms. And what we are discussing is emergency surgery in such
Elective
cases.
surgery.
We are mixing up two cases.
Actually, we are discussing both the cases simultaneously because we cannot leave one part of the same case. So
Okay.
that's the reason. And sir, in elective surgeries, it is very clear that we wait for some time, but if it is an emergency, there is no need of waiting. Surgery sometimes will help the patient in controlling sugars, but in emergencies, we are not doing surgery for control of sugars. Patient's life is far more important. We are thinking about that. We have to do the surgery and rest are to be taken care of. And if at that time there are some risks, we have to take those risks. If for the greater good, those risks are minimal. So that is a different ball game when we are talking about emergency and when we are talking about elective surgery in this case. So, yeah.
I mean, how much of a good glycemic control pre-operatively will decrease the complication rate? Like you said, 1 to 2 weeks is good enough. If we have a good glycemic control, we can take them up for an elective
There
surgery.
are no prospective studies on this, but the complication rates have been compared with taking into effect consideration the pre-op glycemic status. From there, all are extrapolated results only.
Okay.
So, ma'am, in this case, actually, it is about we are not comparing HbA1c to HbA1c. We are comparing the sugar control for those few days before surgery, during surgery, and post surgery, and we have the data for that. But for doing this, we need a patient who was uncontrolled and was operated, which we usually do not allow. And then we have a group which was uncontrolled, not operated, then controlled, and then allowed to operate. So that type of a study, it is very difficult to plan. For now, we don't have any data for that.
No, but from emergency patients, it can be extrapolated, like where we have taken up patients for a life-threatening emergency where sugars were uncontrolled, but we have managed it perioperatively and seen what the outcome is.
Ma'am, so in that case, the sugar level data we have, that every 20 milligram increase in sugar levels will lead to increase in complications.
Okay.
But when it comes to emergency, we are willing to take those risks. But when it comes to elective, we are not willing to take that risk because we can very easily delay the surgery by 7 to 14 days. We are not delaying the surgery for 3 months. First, there is no guarantee that we will be able to control the HbA1c below 7, for which we do not have a cutoff, to be very frank. 7 is a cutoff for good glycemic control. It is not a cutoff for surgery. So that's why we discussed that ADA does not say any cutoff, and some societies say if it is above 8.5, we should think about delaying, and even then they do not ask you to delay for 3 months. So, Dr. Abhilash, what do you say, what will be the glycemic goals in this patient?
Actually, we have all answered that question already. Pre-operatively, the glycemic goals, as you have also told, less than 140 preprandial and more than and less than 180 without hypoglycemias postprandial. Actually, all without hypoglycemias is our target.
And how do you proceed for those goals?
Yeah.
Like
for-
in this patient, patient is on 3 OADs and
Yeah.
uncontrolled with
So
HbA1c
this
of
patient is on full dose of metformin and sitagliptin and almost half the best effective dose of glimepiride, and the patient is not getting controlled. If if I had lot of time, I would have gone for a good diet, exercise, and maybe GLP-1 analogs, etc. But in this patient, we can't do that because she is having a gallbladder disease, which can be sometimes aggravated by some of these medications. And here our only option would be for a fast control. If the patient is decided for a surgery within 2 or 3 weeks, the only option would be insulin, with again a reinforcement of the diet and if possible some exercises. So the targets we have already defined, and always the diet is very important in the, in the management, because as soon as you change the diet, there may be a very good reduction in the blood glucose levels. And on top of that, what insulin regimen you would give is also important. Here, first of all, I will remove glimepiride from her prescription, because it may, at the time of, as the time for surgery nears, there may be problems with of hypoglycemia and titration of the dosages. So glimepiride will be removed. Metformin I will continue till the surgery or 24 hours before surgery. And again, sitagliptin also I will continue through the only for a 24-hour break would be given just prior to surgery. And the insulin regimen would be basal first, and then add on bolus dosage, bolus insulin if the patient requires.
So great, Dr. Abhilash. We always have to reinforce lifestyle and exercise in every patient, diet and lifestyle. And we will start insulin in this patient. Basal and basal bolus are fine. So what if this patient, Dr. Shiva, if this patient was controlled on OADs? Suppose she had a HbA1c of 7 and she had a cholecystitis, she was to be taken for surgery after 2 days or next day. What will be your instructions how to manage those OADs, whether you like to continue all of them, whether you will stop them? What do you think?
Yeah, if the patient is well controlled on OADs, when we say well controlled, the HbA1c of less than 7 or 7.5, then they can be taken for surgery. But there are certain things we have to follow with respect to OADs. The first is the SGLT2 inhibitors. They have a risk of causing euglycemic diabetic ketoacidosis. So when we monitor only the blood glucose levels, we may miss these patients. They end up with metabolic acidosis. They'll have 3+ ketone bodies. But the sugar levels will be 200 to 250. So SGLT2 inhibitors, they have to be stopped at least 72 hours prior to the surgery. And after surgery, you should not start it for at least 2 to 3 weeks till the patient is able to follow the normal diet and is able to follow the usual routine. For the other OADs like metformin, sulfonylureas or DPP4 inhibitors, the patient can continue it till the day of admission and stop it the day before surgery, in the night, otherwise the night before surgery. That is sufficient with the other OADs. Main thing here is the SGLT2 inhibitor. The day when you ask the patient to undergo surgery, ask them to stop it at 72 hours before the day of surgery.
So, very nicely presented, Dr. Shiva. So we still see a lot of patients being offered sliding scale insulin. Do you agree with this, Dr. Abhilash?
Sliding scale insulin in a patient who is on at least some kind of feeds, it is not at all acceptable. Sliding scale should not be given to such patient. Basically, you should have a basal because even in a fasting state, you have some secretion of insulin which is going on from our pancreas throughout day and night. It is not only at the time of having a meal when we are getting the insulin secreted from the pancreas. So if that insulin is also not there, you will go into ketosis. And the thing is, we should always maintain the level of basal insulin the patient requires. And as soon as the patient starts any type of feeding, either oral feeds or nasogastric feeds, the insulin regimen should be converted to a basal bolus regimen, which can be altered later to premix, etc., when the patient becomes more stable.
So very true, rather than chasing the sugars, we should go ahead of them and control them beforehand. In sliding scale insulin, we are chasing the sugars and it is never going to help us. So with this, if there are any questions from our panelists?
Questions? Yeah, please.
Sir, I'm in practice, diabetic practice for last 40 years, and we have been working in a hospital. We have been called upon to control sugar prior to surgery. See, the patient is generally admitted a day or two before surgery, and you are called upon to control sugar. This is a common scenario, very common scenario. And what I have understood till now, that if it is a surgery with low risk of perioperative infection, for instance, urological surgery, a prostatic surgery, you know, you don't have to control sugar rigorously, just control its average. Just make average control sugar and give it to the surgeon. Surgeon is not going to wait for you to control sugar tightly, which we don't normally want. Whatever you say, they will take up the case next day morning, the OT. Before we come to see the patient in the morning, whether sugar is controlled, the patient is already in the OT. And surgeon has taken up, surgery is done. Right? Now, second is laparoscopic surgeries. Mind you, currently, very few infections are occurring in laparoscopic surgery. So, no point in delaying a surgery unnecessarily. Surgeon is restless, right? You will lose the patient if you take 2 weeks. The patient is going to go for window shopping. So, the surgeon is not willing to wait for 2 weeks. And we have to keep a liaison with the surgeon. So, what I personally feel and what has been going on is, in lap surgery also we are not very, very tight on sugar. Yes, for eye surgery, small surgery, cataract surgery, we go tight. There is a serious risk of infection. The surgeon doesn't want to take risk because eye is very clearly, it will show infection directly. Patient, it cannot be hidden from the patient. Right? CABG, I've been working with cardiac units. CABG, we want a very tight control. Right? We insist that you do tight because sternal infection is a real trouble. It's serious trouble. So there we go for tight control of sugar. We insist that surgeon will only operate once we give a clearance. So depending on the type of surgery, we can go a little lenient. On the other hand, we might be very tight on few situations, as I mentioned. So, and HbA1c is irrelevant. See, 3 months, who will wait for 3 months for surgery? This is a business part. Yes, you can't keep the patient waiting and the surgeon waiting for a long time. Surgeon is always restless.
So, but we are here.
So this is my
Sir, in medicine we practice evidence-based medicine, not opinion-based medicine, not restlessness-based medicine. So our duty is to the patient, not to anything else.
Manoj, we have
we should discuss that part rather than the commercial and other angles.
Yes, very right, very right. Manoj, we have to wind it up.
Sir.
Thank you
Please,
so very
absolutely,
much.
absolutely.
It was a wonderful
Please wind
session.
up.
And we were here to learn. We came here as students, no?
Yes, sir. Thank you.
There was a lot of heating debate, but what I could also on a lighter note, कि सर्जन और एनेस्थीसिया वालों का पहले सास बहू का रिश्ता था, पर एंडोक्राइनोलॉजिस्ट के साथ भी ज़्यादा अच्छा नहीं है. So taking it on the light side, sir.